The following podcast is part of a certified educational activity titled Exploring Clinical Decisions in the New Era of Myeloma Management, the Impact of Novel Platforms and Agent Classes Across the Spectrum of Care. Access the entire activity and complete the post-test and evaluation at www.peerview.com/WPW. Downloadable slides and practice aids are also available.
Hello, this is Dr. Luciano Costa from the UAB Comprehensive Cancer Center at Birmingham, Alabama. Welcome to this educational activity on new therapeutic developments in multiple myeloma, during which we will focus on the emergence of several truly innovative new agent classes and what they may very soon mean for patient care. Let's begin with some context and look at how multiple myeloma therapy has changed in recent years. So let's start by mapping the recent changes in multiple myeloma care. The mid-2000s saw the emergence of lenalidomide and bortezomib as drugs that really revolutionized the care of myeloma patients. Ever since, however, we have seen a plethora of new agents and combinations, including carfilzomib, subsequently pomalidomide, later on also a PI ixazomib, panabinostat as a completely new class of drugs in myeloma, the HDAC inhibitors. And early in this decade, we saw the real revolution that were the monoclonal antibodies, initially with single-agent activity data for daratumumab, a combination of elotuzumab or lenalidomide, and in more recent years, very exciting innovative data on combining monoclonal antibodies with either IMiDs or PI platforms. Although the past few years have been very exciting, there's no doubt the future looks equally bright with the rapid development of immunotherapies, mostly aimed at the BCMA, including antibody-drug conjugates, bispecific antibodies, and the CAR T cells. There are, however, other non-immunotherapeutic developments that are also of great interest, such as the appearance of brand new classes of agents in myeloma, such as the XPO inhibitors, the BCL2 inhibitors, as well as other pro-apoptotic molecules. There is also the development of new cytotoxics, new PIs, and new cereblon inhibitors, as well as new classes of HDAC inhibitors in the near future. In terms of the upfront therapy for multiple myeloma, we really started with the VAD platform that has now fortunately come out of use. The first new great upgrade came with the development of thalidomide in the late 1990s, early 2000s, followed by the doublets with lenalidomide, dexamethasone, bortezomib, and dexamethasone. In more recent years, we have seen the triplets become the mainstream of upfront myeloma therapy, not only on transplant-eligible patients, but also in transplant-ineligible patients, including VTD, VCD, and the most popularly used regimen in the United States, RVD. There is a trend of improving upon those triplets with incorporation of carfilzomib as the mainstream PI among those combinations. And I think we all are seeing with great excitement the emergence of data adding a monoclonal antibody, particularly daratumumab, to these triplet backbones. The good news is that those new agents that have really transformed the care of multiple myeloma have impacted the outcomes not only of patients who are on clinical trial or are as fit as patients who are on clinical trials, but also has affected the general myeloma population overall. As we can see in this diagram, if we track the relative survival rate of multiple myeloma patients in the United States from 1993 to 2012, we can see an era-by-era increment in relative survival. Although this diagram gives a measurement of the improvement we have made, also tells us how much we still have to conquer and how much more we need to improve myeloma care. I want to start by summarizing the advances in relapsed refractory myeloma by quickly reviewing recent phase 3 trials that challenge the doublet bortezomib and dexamethasone as mainstream therapy for relapsed myeloma. So we saw a family of trials in recent years. Two of them, the Vantage and the Panorama, demonstrated that the addition of a HDAC inhibitor to bortezomib and dexamethasone, or in the case of Vantage, to bortezomib, improved progression-free survival. The Endeavor trial showed that carfilzomib and low-dose dexamethasone was superior to bortezomib and dexamethasone, not only in progression-free survival, but also in overall survival, solidifying carfilzomib as the preferred proteasome inhibitor, at least in the relapse setting. The Castor trial compared bortezomib and dexamethasone with bortezomib, dexamethasone, and daratumumab, showing a dramatic improvement in progression-free survival, and overall survival data for the trial is still to become mature. Similarly, we also had a family of trials that compare a new therapeutic strategy with the doublet lenalidomide and dexamethasone. The ASPIRE trial showed that the addition of carfilzomib, the second-generation proteasome inhibitor, to lenalidomide dexamethasone improved not only progression-free survival, but also overall survival. The Tourmaline trial gave another option of proteasome inhibitor with the oral ixazomib, also improving progression-free survival when combined with lenalidomide in comparison with lenalidomide dexamethasone alone. The Eloquent trial showed that elotuzumab adds to the therapeutic benefit of lenalidomide and dexamethasone, and the Pollux trial showed that daratumumab, the CD38 monoclonal antibody, greatly reduces the risk of progression when combined with lenalidomide as compared to lenalidomide and dexamethasone. Despite this advance, it remains true that we continue to need newer therapies with different mechanisms of action, particularly as antibodies are moved up front or are used more frequently with IMiDs or PI platforms. For the rest of this presentation, we will look at some of these emerging drug classes and several practical insights on their use. Welcome back. We're now going to explore some of this evidence of novel agent classes in myeloma, including target intracellular therapies and immunotherapies. I will cover target intracellular therapies with the BCL2 inhibitor venetoclax and the XPO1 inhibitor selinexor. Also going to touch on immunotherapy, including newer antibodies, antibody-drug conjugates, and BiTEs, as well as in BCMA-directed CAR T-cell therapy. Let's start with the BCL2 inhibitor venetoclax. So there are several different molecules that work as anti-apoptotic molecules in multiple myeloma cells. Those include BCL2, BCL-XL, and MCL1. Venetoclax is a very powerful and a specific inhibitor of BCL2, displacing pro-apoptotic protein and leading to cell death. The combined use of venetoclax with corticosteroids downgrades the importance of BCL-XL and BCL1, increasing the relevance of BCL2. The same happens with proteasome inhibitors that promotes the persistence of OXA1 and decreases the importance of MCL1, creating a rationale for combination with venetoclax. Venetoclax was initially used as single agent in a phase 1-2 trial, and their overall response rate was a little bit over 20%. But what was quite unique is that near all those responses were among 11-14 translocated patients, with almost no responses seen in non-11-14 patients. And that was reflected on the longer time to progression among patients in that specific cytogenetic subset. This observation was later confirmed on an expansion of that trial, and where venetoclax was combined with dexamethasone, showing an even high overall response rate on 11-14 patients that reached 65%, with overall the response of 50% of all 11-14 patients. Of interest, over 30% of the patients had VGPR or better, showing that to be quite an active combination, particularly considering how heavily pretreated those patients were. A subsequent step was to combine venetoclax with bortezomib due to the potential for synergism that I previously discussed. In that study, the overall response rate was 67%, but if you look among non-bortezomib refractory patients, the overall response rate was 92%, putting that among the most effective regimens described in the relapse refractory population. What I think is of great interest as a proof of principle is that even among the bortezomib refractory patients, a third of the patients had a response, demonstrating that venetoclax can at least partially overcome the resistance to proteasome inhibitors. This observation is being put to test on a randomized trial, the so-called Bellini study, where patients with relapse or progressive multiple myeloma with a COG of up to 2 and 1 to 3 prior lines of therapy are being randomized to venetoclax, bortezomib, and dexamethasone, or placebo, bortezomib, and dexamethasone. This trial has rapidly accrued, and results are expected in the upcoming months. We have seen how venetoclax combines with the PI bortezomib, but can it be combined with the next generation proteasome inhibitors such as carfilzomib? We now have data on the combination of venetoclax and carfilzomib, most recently presented at ASH annual meeting. In that study, we saw that the combination of carfilzomib, venetoclax, and dexamethasone in patients with a median of 2 prior lines of therapy yield an overall response rate of 79%, with about a third of the patients having a complete remission or better. Of great interest, we saw that the rate of response was very similar among IMiD refractory, PI refractory, and even among double refractory patients. Of course, there's great interest in see how the 11-14 patients perform, and with this combination, they perform extremely well, with all patients having a response and near 2/3 of the patients having a complete response. But what is equally interesting is that even among the non-11-14 translocations, the response rate was 74%, which is quite high. And of great interest, we did not see that the cytogenetic risk, high risk or standard risk, affect the likelihood of a patient responding to this combination. In terms of safety for venetoclax in multiple myeloma, grade 3 and 4 AEs are uncommon, most often decreased lymphocyte count, decreased neutrophil count, and hypertension. And that is in contrast with the CLL experience, which is the main disease for which venetoclax has so far been used. TLS does not appear to be a problem. Only very few patients have had TLS with multiple myeloma, and this tends to be 11-14 patients with a high tumor burden. Therefore, ramp-up of dosing is usually not recommended, and patients can be started with the target dose, that being 800 milligrams. Like any other agent, venetoclax has its toxicities, and as we can see, the most common toxicities happen to be digestive system and hematologic system. Of importance, most of the toxicities are grade 1 and grade 2, and grade 3 and 4 toxicities or toxicities leading to treatment discontinuation are very uncommon. In summary, we have seen that venetoclax is a well-tolerated agent that is active in combination with dexamethasone in patients with translocation 11-14 and has active in combination with PIs in all the cytogenetic subsets. In myeloma, there's no need to ramp up dosing as done in CLL, and 800 milligrams is the ideal dose. TLS is uncommon, but watch for in 11-14 patients with a high tumor burden. To illustrate some of these points, here's an example of a patient I think could be an ideal candidate for venetoclax therapy. So Mark is a 77-year-old with stage 2 multiple myeloma that has been managed for 7 years. Initially, he received induction therapy with RVD, followed by an autologous transplant and lenalidomide maintenance. After 4 years, he experienced a progression and then received VCD with only a partial response. After progressing on VCD, Mark was treated with daratumumab, pomalidomide, and dexamethasone with a partial response and later at relapse. In terms of therapeutic choices for Mark, I believe he would be an excellent candidate for a carfilzomib-based regimen, and I would choose carfilzomib, venetoclax, and dexamethasone, given the excellent results and adequate safety profile seen on the phase 2 study recently presented, and based on the fact that he is now refractory to has been exposed to 2 IMiDs, is refractory pomalidomide, and also happens to be refractory to daratumumab. What about some other settings where venetoclax may be useful? I think they include in combination with dexamethasone for 11-14 patients with 2 or more prior lines, or with 1 prior lines and poor candidates for infusional therapy, a patient that you desire an all-oral regimen. But I also think that venetoclax can be used in combination with a PI as second or subsequent lines of therapy, and I would preferentially use as a second line of therapy for patients who happen to be 11-14. Let's switch gears a little bit and talk about selinexor. Selinexor is an inhibitor of exportin 1 or XPO1. XPO1 is located in the nuclear membrane, and it's essentially a pump that excludes from the nucleus several different molecules, including several tumor suppressor genes. Therefore, if you can antagonize XP1 and keep those tumor suppressors within the nucleus, you can potentially have an anti-tumor benefit. One of those receptors happen to be the steroid receptor, creating, therefore, the rationale for synergy between selinexor and corticosteroids. We have recently seen data on the phase 2 STORM trial. This is one of the first trials that really focus on a heavily pretreated population that happens to be exposed to 2 IMiDs, 2 PIs, and be refractory to at least 1 IMiD, 1 PI, and refractory to daratumumab, which we now know is a very difficult population to treat. This trial enrolled 122 patients and saw an overall response rate with 26.2%, which is considered encouraging for such a difficult population to treat. Some of those responses were very deep, including 6.5% or very good partial response. Median progression-free survival was 3.7 months, and median overall survival was 8.6 months in this population. Of interest, and as is often the case, patients who happen to have a response had substantial gains in overall survival, reaching 15.6 months versus 1.7 months in patients who did not respond. In terms of safety profile, we're seeing here toxicities that led to treatment discontinuation, and those are experienced in about 30% of the patients. There are some toxicities that are uncommon for multiple myeloma agents, and that we all going to have to become familiar with as we manage patients on selinexor. They include nausea, other GI toxicities, occasionally hyponatremia, fatigue, and thrombocytopenia that require some management, including with thrombopoietin mimetic agents. So let me summarize the data that we have seen so far on selinexor. Selinexor is active in combination with dexamethasone in heavily pretreated patients that have been exposed to IMiDs, PIs, or refractory to both classes of agents, and also refractory to daratumumab. In this very difficult population, selinexor was found to be active in about a quarter of the patients. We also have seen data of selinexor being active with PI platforms, as well as in combination with daratumumab and pomalidomide, and those data looks very promising, and we look forward to subsequent trials. The most important trial currently being performed is the so-called Boston trial. This is a phase 3 study where selinexor with bortezomib and dexamethasone is being compared head-to-head with bortezomib and dexamethasone in patients with relapsed or refractory multiple myeloma with 1 to 3 prior lines of therapy. This trial should give us the definitive answer of whether selinexor can add to bortezomib on treating patients with relapsed multiple myeloma. In summary, selinexor is an innovative agent with unique mechanism of action, has the convenience of the oral administration, and has unique and substantial toxicities that require some active management. Let's look at a case that illustrates what kind of patient would be a candidate for selinexor based on evidence we have seen so far. Let's think of Ellen. Ellen's a 75-year-old woman with multiple myeloma for 9 years. Ellen's initial therapy was Cybor-D, followed by an auto transplant and lenalidomide maintenance. She progressed after 5 years and was treated subsequently with carfilzomib dexamethasone, elotuzumab, lenalidomide dexamethasone. Both regimens met with subsequent progression. Ellen is currently being treated with daratumumab Pomdex, but she's experiencing disease progression. She has good performance status, adequate kidney function, and minor cytopenias. We think that Allen's case very much resembles the population that was included in the STORM trial. Therefore, selinexor with dexamethasone would be a great option for her. Let's now turn to the clinical potential of immunotherapy in multiple myeloma, where we have several innovative antibody and adoptive cell therapy strategies in development, including bispecific antibodies and CAR T cell therapy. I want to start by telling you about BCMA, which I consider a near-perfect target for therapy in multiple myeloma. As you can see in this diagram, BCMA is expressed very late in the B cell development, therefore is encountered only in late B cells and in plasma cells, which are nothing but very mature antibody-producing B cells. BCMA is not expressed in enough quantity in other hematologic cells and is also not expressed in other non-hematologic tissues. Multiple myeloma cells, as plasma cells, almost ubiquitously express BCMA, although the density of the antigen may vary. And the same thing has been seen in multiple myeloma cell lines. One of the ways to explore BCMA as a therapeutic target has been through bispecific T-cell engagers. Those are really artificial molecules produced by two FAB molecules that are from antibodies aimed at CD3 to engage T cells, and antibody aimed at BCMA to engage the plasma cells. When put together, they form a BiTE that has the capacity to approximate in the microenvironment of the tumor T cells and the cell of target, in this case plasma cells, activate the T cells and lead to tumor kill. Let's review the data that recently presented on AMG 420. This is a single-agent phase 1 trial for patients with relapsed refractory multiple myeloma. This trial was done predominantly in Europe and enrolled 35 patients with at least 2 prior lines of therapy, including PIs and IMiDs. About a third of those patients had also received daratumumab therapy. This study found the dose-limiting toxicity of this agent to be 800 micrograms a day, and there was mostly cytokine release syndrome and peripheral neuropathy. Therefore, the 400 micrograms a day is likely to be the dose to be developed. At a higher dose, particularly at the 400 micrograms a day, we saw that the majority of patients have a response, including patients who had MRD negative response, which is very exciting in this population. Another way to explore BCMA as a therapeutic target is through antibody-drug conjugates. The agent that's further along in development is GSK 2857916 that combines BCMA-bound antibody with MMAF, which is a potent tubulin poison. In phase 1 trials, incredible activity was seen at doses greater than 3.4 milligrams, leading to expansion of that cohort and yielding a 60% response rate in a heavily pretreated population with median prior lines of therapy of 5 regimens. What is unique about this agent is the corneal toxicity that was seen in a substantial number of patients. The corneal toxicity tends to be mild and moderate and is reversible and treatable and preventable with corticosteroid eye drops. This agent also had other toxicities, including mild to moderate hematologic toxicity. Let's look at yet another way to explore BCMA as a therapeutic target. This is the way that has created the most expectation in the recent months and years. We talk about CAR T cells, which is a very unique therapy in the sense that it requires the production of an individual therapy for each specific patient. The process starts with leukapheresis for collection of lymphocytes. T cells are selected, enriched, and transfected with a virus carrying a chimeric antigen receptor that is able to recognize BCMA. After several quality control steps, This product is then released for the patient to be treated. In this meantime, the patient undergoes lymphodepleting therapy, typically with fludarabine and cyclophosphamide, creating the right immunologic environment for acceptance of those T cells and thriving of those T cells. Once those cells are infused, they are expected to meet the target present in the multiple myeloma cells, which leads to both killing of the cells containing the target as well as expansion of those T cells, which is responsible for often very quick tumor response. What I'm showing here is the diagram for BB2121, which is one of the platforms that is further developed. The data shown so far has been a phase 1 trial with escalation of dose, and patients have been treated to up to 800 times 10 to the 6 cells. This trial includes both patients who had a high expression of BCMA as well as low expression of BCMA. As we can see, among the 43 patients treated, the majority had received multiple lines of therapy, 100% had received daratumumab, and the vast majority were refractory to most multiple myeloma agents that we know. In terms of toxicity, the unique toxicity of these agents is the cytokine release syndrome, which is a syndrome of fever, tachycardia, occasionally hypoxia, that can really evolve into frank organ failure. Fortunately, most CRSs were grade 1 and grade 2 and manageable, and grade 3 CRS were uncommon, the same applying for neurotoxicity, which is another unique and sometimes frightening toxicity of this type of agent. Other toxicities are hematologic and also infection, probably driven by the fact that the therapy requires a cytotoxic regimen to be given right before the CAR T cells are infused, which leads to some transient but often profound cytopenias. So this is a summary of the CRS seen with this agent. About 60% of the patients experience a CRS, the vast majority being grade 1 and grade 2. Of interest, as you can see on the right side panel, CRS was more common among the patients who receive a higher dose, further endorsing the theory that CRS is driven by the activation of the T cells and engagement of the T cells within the target. Similarly, we also saw that not only toxicity was affected by the dose of cells, but also efficacy. Among patients who received greater than 150 times 10 to the 6 cells, overall response rate was 95.5%, which is extremely high and encouraging considering how heavily pretreated those patients were. Of great interest, we saw that the tumor response was not directly affected by the expression of BCMA, showing that even patients whose multiple myeloma cells express a relatively low density of BCMA can still respond to this very powerful therapy. I want to go ahead and summarize the efficacy of BB2121. A dose is equal or higher than 150 times 10 to the 6 CAR T cells. This platform induces deep and often durable responses in this population that is heavily pretreated. For the overall study, the median PFS was 11.8 months, but there were 16 patients who are responding and tested MRD negative, and for those patients, the median PFS was close to 18 months. We saw the comparable overall response rate was seen in patients with low and high BCMA expression, and we saw a very clear dose-response relationship as the doses got increased. We also saw that patients who turned out to be responder had a much greater expansion of the CAR T cells than the patients that did not respond to this therapy. In terms of safety, the most interesting aspect is the CRS that was mostly grade 1 and grade 2, and often, or not always, reversed with tocilizumab and or corticosteroids. There were few grade 3 events and one case of grade 4 neurotoxicity with no additional toxicity event seen in the expansion cohort. BB2121 is not the only platform for CAR T cells. This diagram shows other CAR T cell platforms all aimed at BCMA that are in more advanced development. Just recent at the ASH 2018, we saw an update of the LCAR B38M that shows an overall response rate of 88%, although those patients were less heavily pretreated than the patient population on the BB2121 trial. We also saw, for the first time, data on JCAR-H125 with overall response rate of 82%, including 27% of complete remissions or stringent complete remissions. It's important to understand, even though we have been floated with new data on CAR T-cell and several different platforms, each of them is very unique, has a different construct, a different production process, and the trials have different eligibility, and they have different safety profile. It is therefore important that we stay attentive to those details as the data matures and more patients are treated. I want to go ahead and summarize the different strategies of targeting BCMA in multiple myeloma. The BCMA antibody drugs conjugate have very promising activity, have a convenient schedule, have a favorable safety profile, but we need to be attentive to the ocular toxicity that is quite unique and often requires a partnership with an ophthalmologist, something that multiple myeloma physicians are not very used to. The BCMA T-cell engagers have the advantage of being an off-the-shelf product. CRS is expected and requires management in a specialized setting, and the data, although very encouraging, is very preliminary. CAR T-cells have shown to have fast and deep remissions. CRS is mostly mild and managed successfully in most cases. However, its administration requires a complex operation with intense monitor and recognition and management of the CRS and neurotoxicity events. It's unlikely to be used outside tertiary centers. In summary, I think that we have seen here today is that as clinicians treating multiple myeloma patients, we are on the cusp of a new treatment era in which offer us choices beyond IMiD and PI-based platforms. To best prepare for the emergence of BCL2 and XP1 inhibitors or new immunotherapy agents, it's our responsibility to understand how these agents work and their unique safety and efficacy profile. I hope this activity has been informative and useful for your practice. Thank you again for joining me.
Thank you for listening. Download materials and complete the post-test and evaluation for credit at www.peerview.com/WPW. This activity is supported by an independent educational grant from AbbVie. This activity has been jointly provided by University of Nebraska Medical Center, Center for Continuing Education, and PVI, Peerview Institute for Medical Education.